I would like to ask Dr. Kirilov now to have the presentation about surgical treatment of aortic endograft infection.
So, hello, dear colleagues, it's a pleasure for me to be here. Today our case is about surgical treatment of infected aortic stent grafts. Endovascular treatment of aortic aneurysms has gained popularity over the past 20 years, although rare complications do occur, one of the most dangerous one being infection of the stent graft. It is often complicated by fistulas between the prothesis and intestine, sepsis, endoleak, and disconnection with subsequent distal migration of the stent graft. It's a rare condition, accounting for 0.5 to 6% of aortic graft insertions. It's a serious condition with almost 100% mortality rate if in 2 to 3 years if left untreated. The diagnosis is made by a combination of clinical, surgical, radiological, and laboratory findings. Complete surgical graft removal of the infected prothesis is highly desirable, and use of infection-resistant graft material is also desirable. Antimicrobial therapy is vital adjunct to surgery. Complete removal of the infected prothesis is not easy. It carries about 20 to 30% mortality rate. The first case is of 65-year-old gentleman who was transferred from another hospital as an emergency. He underwent EVAR 2 months ago on the occasion of trip away. Post-procedure, he had fever up to 39 degrees, elevated inflammatory markers. Serratio was isolated from blood culture. CT evidence of perigraft fluid. A 2-month course of antibiotic was carried out without effect. So objectively, we find a wound with purulent secretion in the left inguinal region, pain in the left paravertebral region, fever, fatigue, and weight loss. PET-CT shows stent graft infection, inguinal zone infection, abscess between intestines and psoas muscle, and laboratory data for systemic infection too. You can see on the PET-CT the glowing of the areas which has increased metabolic activity. So a decision was made to expand the infected EVAR and replace it with a biological bovine pericardium graft. During the preparation, bleeding occurred from the left femoral area and emergency surgery was required. 2 teams working. The first one performs the abdominal access and the second one sews the biological prothesis. This is the occlusion of the left branch for hemorrhage control. The balloon was introduced via open brachial artery exposure. This is the removed stent graft and the extensions. And the removal of the main body is more challenging than the extension because of the fixation barbs, which can damage the aorta when doing the explantation. This is the complete physician-made bovine pericardium graft, and this is the done implantation. So we chose to close the abdominal cavity with a vacuum device to remove infectious fluids and reduce intra-abdominal pressure. After the operation, patient was treated with antibiotics until negative blood cultures and normal laboratory findings. From the control CT, there was no evidence of perigraft infection. The second case is of 69-year-old gentleman transferred from another hospital as an emergency. He underwent EVAR 2 months ago for asymptomatic infrarenal abdominal aortic aneurysm with diameter 5 centimeters. Post-procedure, he had fever up to 39 degrees and Staphylococcus aureus was isolated from blood culture. The clinical data show diffuse abdominal pain, nausea, and vomiting, increase of laboratory markers of infection, and the PET-CT shows stent graft infection. So this is a clip from the operation after the dissection of the aneurysmal sac proximal and distal control. The aneurysm sac was opened. You can see that the surgical clump is actually not clumped. So the clumping is again done via a reliant balloon, and the surgical clump is just in case. So if the balloon ruptures when we remove the crown. This is the explantation of the main body. Here we use a 20 cc syringe to infold the graft on itself, so we can retract the barbs so then they don't do too much damage to the aortic wall. This is the finished biological graft that was implanted. And in conclusion, in cases presented, treatment was initiated with a big delay. This led to the spread of infection in the periaortic tissues, which made the surgery extremely difficult. The so-called second hook operation was necessary in both cases due to the risk of residual infection in the operative field. The recovery period was long and difficult in both cases. So the take-home message is: read the whole book and don't skip the pages. Be ready to deal with complications, not just the primary procedure. Often the treatment of complications after EVAR is much more difficult and with much more high mortality rate than the primary procedure. And the success of the operation of infected stent graft is often influenced by the time since the onset of infection. Thank you.
Okay, thank you very much.
Thank you.